Welcome to the debate. Today we are taking on one of the most profound and genuinely polarizing issues in modern society. We're looking at the ethics, the legality, and the public health implications of abortion.
Right, and we are grounding this discourse in the shifting global landscape, but particularly looking at the reality in the United States post-Dobbs v. Jackson, which, as we know, overturned nearly 50 years of constitutional protection for abortion access.
Exactly. So our central question today is really this. Does the moral weight of a fetus's potential future override a pregnant person's fundamental right to bodily autonomy? And how should society weigh the documented socioeconomic and public health impacts of strict abortion bans?
To navigate all of this complexity, we're drawing on a really comprehensive body of source material today. We've got global health statistics from the World Health Organization, legal histories, state-level data from the Kaiser Family Foundation, and we'll also be heavily referencing the empirical findings of the UCSF Turnaway study alongside foundational philosophical essays, particularly those by Judith Thomson and Don Markey, to test the ethical frameworks here.
Right. We want to look at the philosophy and the data. I will be arguing that bodily autonomy is absolutely paramount and that restricting abortion causes profound, empirically documented harm to public health, socioeconomic stability, and marginalized communities.
And I will argue that the fetus possesses an intrinsic moral value and a valuable future, meaning the ethical duty to protect vulnerable human life must place significant principled limits on abortion access.
Let's begin about laying out our core frameworks. From my perspective, access to abortion is inextricably tied to bodily autonomy and, by extension, gender equality. Society widely accepts the philosophical premise that no individual has the right to use another person's body to sustain their own life without ongoing consent. We don't force people to donate organs or blood even to save a life. The right to control what happens to and within one's own body is a prerequisite for participating equally in society. When we strip that right away, we don't just create an abstract ethical dilemma, we create measurable, devastating realities.
Whoa.
And the empirical evidence on this is overwhelming. Decades of research demonstrate that denying abortion access directly leads to severe physical, mental, and economic hardships for the pregnant person. If we value human well-being, we must recognize that forcing a person to carry an unwanted pregnancy to term is a profound violation of their fundamental rights.
The framework I advance centers on the moral status of the fetus and what we actually do when we terminate a pregnancy. I draw heavily on philosopher Don Markey and his argument from loss. When we ask ourselves why killing an adult human being is morally wrong, the most robust answer is that it deprives that individual of a valuable future. All the experiences, activities, projects, enjoyments that would have constituted their life.
Okay.
A fetus is a potential human life with a future like ours. Depriving it of this valuable future is a profound moral wrong. Now, I want to be clear here. The physical, emotional, and economic burdens of pregnancy are very real, and society has a massive obligation to alleviate them. However, our moral responsibility to protect a developing, uniquely vulnerable human life requires us to prioritize fetal protection over an unrestricted right to choose. The intrinsic value of life has to be the bedrock of our ethical reasoning.
I think the best way to really dig into this is to look closely at the philosophy of personhood and bodily autonomy, because that is where these two frameworks violently collide. Even if we grant your premise for a moment that a fetus is a full person with a right to life, we still have to address the mechanics of bodily dependence. J.J. Thomson's famous violinist analogy illustrates this brilliantly, and it represents a massive paradigm shift in how we think about rights.
It is certainly one of the most famous thought experiments in modern philosophy.
Exactly. For those who aren't familiar, Thomson essentially asks us to imagine waking up one morning to find that the Society of Music Lovers has kidnapped you in the middle of the night. You wake up medically plugged into a famous unconscious violinist who has a fatal kidney ailment. The hospital director tells you, look, we're sorry they did this, but if you unplug yourself right now, the violinist will die. He only needs your kidneys for 9 months, and then he'll be cured.
Right.
Thomson argues that while it might be a tremendous kindness to stay plugged in, you are not morally obligated to do so. The violinist's right to life does not encompass the right to non-consensually use your bodily resources.
I see why you think that, but let me give you a different perspective. Even if we completely concede fetal personhood, the right to life does not grant anyone the right to occupy another person's body. The moral permissibility of abortion rests on the right to withdraw bodily support.
I come at it from a different way. Thomson's analogy is a striking image, but its application to standard pregnancy is highly problematic. Think about the scenario you just described. A random, violent kidnapping where two completely unrelated strangers are artificially connected. But pregnancy, in the vast majority of cases, is the result of consensual biological processes. A fetus is not an invading stranger. It is the natural offspring of the parents, developing exactly where human biology dictates it should develop.
But suggesting that consensual biological processes imply ongoing consent to bodily use is quite a leap. If you open a window to air out your house and a burglar climbs in, you don't suddenly forfeit your right to remove the burglar just because you voluntarily open the window knowing the risks. Engaging in an act that carries a known risk does not legally or morally oblige one to surrender their bodily autonomy if that risk materializes.
But a child is not a burglar, and relying purely on the bodily intrusion argument completely bypasses the nature of the harm being done. This is where Markey's argument from loss becomes so critical. Abortion doesn't just unplug a biological connection, it actively terminates a future like ours. The core wrongness of killing is the deprivation of that future. When you combine the natural biological relationship between a mother and child with the catastrophic loss of a valuable future for the fetus, Thomson's analogy simply cannot support the weight of unrestricted abortion on demand. You cannot compare the natural creation of life to a violent abduction by a society of music lovers.
But whether it's a stranger or a biological relative doesn't change the fundamental right to your own organs. We wouldn't force a parent to give up a kidney to save their born child either. But let's step out of the abstract philosophy for a moment, because what really happens when we prioritize fetal potential over maternal autonomy isn't a thought experiment. It's happening right now, and the empirical health and socioeconomic impacts of abortion bans are staggering.
You're referring to the Turnaway study here.
Yes, the USCSF Turnaway study, which is arguably the most rigorous research we have on this topic. They tracked 1,000 people over 5 years, comparing those who received abortions to those who were turned away simply because they were past a clinic's gestational limit. The data is concrete and deeply unsettling. People denied abortions face 4 times greater odds of living below the federal poverty line. They're 3 times more likely to be unemployed. We're talking about people who are more likely to face evictions, unable to afford basic living expenses, and end up relying heavily on public safety net programs.
And the health outcomes.
They are just as alarming. Those turned away face much higher rates of life-threatening physical complications. For instance, eclampsia, which is this incredibly dangerous condition where high blood pressure leads to seizures during pregnancy. They also experience worse long-term health and chronic pain. If you actually look at what happens on the ground when these bans go into effect, the health and economic fallout is catastrophic. The data clearly shows that abortion access is fundamentally an issue of public health and economic survival.
That's a compelling argument, but have you considered what these statistics actually reveal about our society? I do not dispute the findings of the Turnaway study for a moment. The hardships faced by vulnerable mothers are heartbreaking, and the cascading effects of poverty, like eviction and ruined credit, are entirely real. But we must ask ourselves a very uncomfortable question. Is terminating a developing human life the ethical remedy to poverty and systemic inequality?
It is the ethical remedy to forced gestation.
But look at the underlying motivations the study reveals. If a woman is seeking an abortion primarily because she is facing unemployment or because she fears falling below the poverty line, that is a glaring indictment of our social safety nets. It is an indictment of our workplace policies and our community support structures. The solution to maternal poverty should not be the elimination of the fetus. The solution should be comprehensive health care, paid family leave, child care support, and direct economic assistance. Using abortion as a band-aid for societal failures sets a dangerous precedent. We are essentially telling marginalized people that their only path to economic stability is to forfeit their potential children.
That's an interesting point, though I would frame it differently.
I completely agree that we need vastly improved social safety nets. No one should have to choose between having a child and paying rent. But restricting abortion doesn't magically produce those safety nets. It merely traps people in poverty while we wait for a utopian systemic change that may never arrive. You can't deny someone health care today because you wish society functioned better tomorrow.
It isn't about wishing for a utopia, though. It's about not using lethal means to solve economic problems.
But it's also about looking at the broader global context, because the divergence between the rest of the world and the U.S. post-Dobbs landscape is alarming. Globally, the unmistakable trend over the last 30 years has been toward the liberalization of abortion laws. The World Health Organization data shows that in countries where abortion is broadly legal, abortion rates have actually declined by 43% between 1990 and 2019.
Because liberalization is often paired with better contraceptive access and healthcare.
Exactly. But conversely, in countries with severe restrictions, rates have slightly increased. And this is the vital part. Almost 90% of abortions in those restricted regions are considered unsafe. We are talking about procedures that account for 5 to 13% of global maternal deaths. Now, contrast that global progress with the United States today. We are seeing severe bans that disproportionately impact marginalized groups. According to the Kaiser Family Foundation, 60% of Black women and 59% of American Indian and Alaska Native women of reproductive age live in states with abortion bans or tight restrictions. The public health outcomes of these bans are highly unequal, and they are incredibly dangerous.
We definitely have to analyze the global landscape carefully, but I think the U.S. discourse often misrepresents international norms. Yes, there has been a trend toward liberalization, but international norms are much more nuanced than a simple binary of legal versus illegal. You mentioned Europe, which is often cited as a progressive standard, but European countries heavily regulate abortion.
They provide access, though.
They do, but with significant limits. France recently made international news for enshrining abortion rights in its constitution, which was heralded globally. But what is almost always omitted from the U.S. conversation is that France maintains a gestational limit of 14 weeks for abortion on request. Many European nations balance the competing moral interests by allowing access early in pregnancy while increasing protections for the fetus as it develops.
That is still vastly different from a total ban at conception, which is what many U.S. states now have.
True, but consider where the U.S. was prior to the Dobbs decision. Under the standard established by Roe v. Wade and Planned Parenthood v. Casey, viability, the point at which a fetus can survive outside the womb, roughly around 24 weeks, was the baseline. Under that standard, the U.S. was actually a global outlier in how late it permitted abortion on request. The shift we are seeing now with Dobbs returning power to the states represents a democratic process. It allows communities to debate and establish their own moral standards regarding fetal life. It is an attempt to find a societal compromise that reflects the deep moral reservations many citizens hold about ending fetal life, particularly as science provides us with clearer windows into the womb.
I'm not convinced by that line of reasoning because the idea of a democratic compromise breaks down completely when we look at the role of the medical provider and state enforcement in the real world. We aren't seeing compromise. We are seeing draconian enforcement. Under these new state-level bans, the doctor-patient relationship is being severely damaged. Physicians are facing severe criminal penalties, which forces them to delay life-saving care until a pregnant person's health deterioration is deemed imminent.
The laws usually include exceptions for the life of the mother.
In theory, yes, but in practice, we have seen high-profile cases like in Texas, where patients with dangerous infections or carrying fetuses missing parts of their brains are denied care because doctors are terrified of prosecution. You have doctors sitting in emergency rooms consulting hospital lawyers while their patients are bleeding out. You cannot safely accommodate medical exceptions when the threat of decades in prison hangs over the physician. Imminent threat to life is a legal standard, not a medical one, and it paralyzes doctors.
Those are implementation failures, which are tragic, but they don't invalidate the law's intent.
But it goes beyond just poorly written state laws. We are seeing aggressive, overarching state enforcement strategies. Look at the attempts to revive the Comstock Act. This is a 19th century anti-vice law that was originally meant to stop the mailing of obscene materials.
Now, legal strategists are dusting it off to try and restrict the mailing of medication abortion, like mifepristone, nationwide, even into states where abortion is entirely legal. This is not about community compromise or letting voters decide. It is a sweeping enforcement regime that supersedes medical ethics, ignores state sovereignty when convenient, and endangers lives.
I'm sorry, but I just don't buy that. Let me tell you why. You're pointing to the most challenging edge cases and the roughest edges of newly drafted laws to invalidate the entire premise of fetal protection. Statutes can and must be refined to explicitly protect the life of the mother without ambiguity. No one wants doctors waiting for a patient to crash before intervening. But since we are talking about medical ethics, we also have to talk about it from the provider's perspective, specifically providers who recognize the moral weight of the fetus.
You mean conscientious objection?
Exactly. Under international human rights law, conscientious objection is a recognized right. Over 80 countries expressly allow healthcare providers to refuse to provide abortion care based on their moral, religious, or ethical beliefs. According to the UN Working Group, while governments must ensure this doesn't create systemic barriers to care, medical professionals should never be legally compelled to perform procedures they view as morally equivalent to ending a human life.
But how does that work in an emergency?
The emergencies are generally treated as exceptions. But for standard care, regulating conscientious objection should not mean erasing a provider's moral agency. If a doctor deeply believes, backed by the biological reality of fetal development, that they are dealing with two patients in that exam room, the mother and the unborn child, forcing them to terminate one of those patients is a profound violation of their own conscience and professional ethics. We cannot build a medical system that forces doctors to betray their deepest moral convictions about the sanctity of life.
But conscience rights for providers must always be balanced against the patient's right to non-abandonment and timely care. If a provider's objection results in a delay that causes a woman's uterus to rupture or forces her to travel across state lines while miscarrying or traps her in systemic poverty, that provider's conscience has functionally weaponized the state against the patient.
Which is why the UN stresses balancing that right so it doesn't create systemic barriers. But you cannot simply strip the provider of their moral agency.
And this circles back to the core of my position as we summarize our discussion today. The extensive empirical data we've discussed, from the granular realities of the Turnaway study to global maternal mortality statistics, proves that forcing individuals to carry unwanted pregnancies violates their fundamental bodily autonomy and leads to documented systemic harm. It isn't just an abstract philosophical debate. It traps marginalized populations in poverty, damages long-term physical and mental health, and severely compromises the ability of physicians to provide standard medical care. Recognizing bodily autonomy is the only way to ensure individuals can participate fully and equally in society without being reduced to gestational vessels against their will.
And my summary rests on the unavoidable reality of what is actually occurring during a pregnancy. The unborn fetus is an incredibly vulnerable, developing human being with a future like ours. Recognizing the profound moral weight of that potential future demands that we construct legal and ethical protections for it, even amid incredibly challenging socioeconomic circumstances. To simply treat fetal life as disposable in the name of autonomy is a failure of our moral imagination. While the burdens on the mother are vast and deserve immense societal resources, the fundamental human right to life must logically precede all other rights. We cannot build a truly just society by resolving economic or personal hardships through the termination of our most defenseless members.
Both perspectives ultimately seek a society that values human well-being and flourishes. We clearly share a mutual concern for maternal health, recognizing that women facing crisis pregnancies are in need of deep structural support. We also both agree on the necessity of reducing unintended pregnancies through better access to contraception.
I agree completely. And we both acknowledge that the systemic failures in family support in this country, like the lack of paid family leave, affordable childcare, and accessible healthcare, are ongoing crises that deeply exacerbate the abortion debate and desperately need addressing. The tension we've explored today highlights the profound complexity of balancing deeply held moral convictions about the sanctity of life with the very real demands of bodily autonomy and healthcare access.
it is a profound complexity. The extensive source material we've discussed today, from philosophical models like Thomson and Marquis to global policy tracking, offers so much more to explore regarding the legal, medical, and ethical nuances of this issue. It is a debate that requires constant, rigorous, and empathetic examination. Thank you for joining us for this discussion, and we leave it to you, the listener, to reflect on these arguments, examine the evidence, and form your own conclusions.